I just want to remind everybody about what people expect of us. We're members of society. We are no better than any other members of society. We are part of society. We need to act within it. And what people expect of us, I've put in this little pyramid here. We act with respect towards patients. We act ethically. And at the very base of that is competence. Now, everybody in this room, fellow or trainee, has unique competence in pain medicine. And I just want to remind people about how important this is and why this can sometimes get lost. Without these elements of professionalism, we are never going to develop the trust that's expected of us as specialist physicians. When I talk about competence, we're actually going back to what it basically means to be a doctor. And some of that gets lost. So I want to concentrate on our little mind map again. And along the top branch, we're going to magnify it a little bit. And in particular, I want to concentrate on the area of skills. Because skills are what are most necessary for patients, and skills are what patients expect of you. And one of the fundamental skills that I feel needs to be central to pain medicine is the skill of diagnosis. Now, recently, I was visiting a unit and I tried not to bite my tongue in half when I was told by a senior fellow in the pain unit that we don't take anybody without a diagnosis. Well, interesting that. How do you know the diagnosis is right? I mean, if the diagnosis is visited by aliens in southern Alabama, okay, yeah, I'll take that, but perhaps not. Maybe you need to look at something else. So, diagnosis is part of the process of good medicine, and it's an incredibly important part of the process of pain medicine for a number of reasons, not the least of which is everybody in this room is uniquely positioned to make a diagnosis. In some ways, it's more similar to psychiatry than other parts of medicine because it's made along different axes. Now, diagnosis has a long history, and obviously we're aware that we can bring tools to bear on diagnosis. So this wonderful cartoon here is still one of my favourites. But obviously, there are some diagnoses, some conditions that are obvious, and being a woolly mammoth is one of them. It gets a little bit more complicated when we talk about pain medicine, though, because obviously we have overlapping elements of biomedical factors, we have psychological factors, and we have social factors, and these three are quite different. For some reason, psychological and social often get bundled into the same term. They're not the same. Psychosocial is nothing. It's a neologism. There's psychological factors and social factors, and they're separate, but they influence each other. But of course, unless we know what we're dealing with, we actually see what the baffled person in the middle sees, which is just a confusing mixture of all three. Now, the problem is, parts of that are often ignored. And I'm just going to go through a few examples. These are all in recent years from clinical practice, so these are not rare in pain medicine practice. These happen to be taken from my own clinical experience. But 4 years ago, an eminent academic physician in Adelaide asked me to catch up with a friend. And so here we have this person. She's a 63-year-old lady and referred to me with fibromyalgia. Now, immediately there's something a little bit unusual sitting down with this lady because she doesn't have fibromyalgia. She actually has very localized pain in some peripheral joints. And the way she describes this is, again, totally different from fibromyalgia. So the first thing is, this is a person who's been sitting down in social circles with lots of doctors. She's been complaining about pain in multiple areas, and someone has come to the conclusion because they can't explain it, they'll give it an inexplicable diagnosis, i.e. fibromyalgia. Few things though about this, and we're going to have a few examples of this as we go through this aspect of professionalism, and that's diagnosis. So I start talking to this lady. The first thing talking to this lady is that this lady is not a fibromyalgia patient. And I don't mean that disparagingly. There's just a simple difference in attitude and expression. But of course, the next thing is, even before I've started looking at conducting a physical examination, I'll just have a look at her hands. And I say to her, "How long have your nails been like that?" To which the question is replied in the following. So in other words, we have an Indonesian nail technician who has spotted that there's something a bit odd about this lady's nails, whereas all the doctors that she's been socialising with in Adelaide have actually missed this. Now, as it happens, in my rooms in Adelaide, Fowler Simmons Radiology is literally across the corridor with a CT scanner. So I sent her across the corridor for a CT scan, and unfortunately, and perhaps unsurprisingly, this is what we found. So this is somebody whose nails, who had developed profound clubbing at least 18 months previously, and now has this cavitating lung lesion. Unfortunately, this lady is no longer with us, as you would not be at all surprised to hear. So let's go back to basics. When someone comes to the pain clinic, you are seeing them as a new patient. They've often been to see many other specialists beforehand. You can be light-hearted about it. I say to patients coming to see me, "You'll be pleased to hear that you've come to a resort." And they say, "Really?" "Yeah, it's the last resort, but you've come to a resort." But the important thing is, start again. Because the number of people who have been through multiple specialists, as soon as the word chronic pain is mentioned, there's a part of the brain that sort of switches off, and I think it's probably something down in the brain stem, frankly, in terms of the way that so many of our patients have been ignored.